So this is I picked some cases to represent what we do in EP in general for an audience that doesn't do necessarily EP clinical on the clinical side. So I just wanted to show you what we do and what potentially we could need to advance the field from technology standpoint. So we're going to go focus mostly on the catheter ablation side of things, not the device implants. So I'll start with explaining some of the mechanisms of tachyarrhythmias. There are three main mechanisms that helps us figure out how to map these and how to think about them. Number one, automaticity. Number two, triggered activity. And number three, re-entry. And we'll explain them briefly. So I'll start with automaticity. Automaticity is there's a group of cells that spontaneously generate an impulse without an external stimulation. Our sinus node generates what we call normal automaticity. It generates our sinus node, our impulse, every 60 beats per minute, 70 beats per minute. Sometimes there are a group of cells that show what we call abnormal automaticity, meaning it generates an impulse, but they're not really designed to. They get actually in the way of the sinus node. And then what happens is here, as you can see, the phases of impulse generation. In the sinus node, you see that phase 4 is there's a trickle of calcium that goes in all the way until it reaches the membrane threshold, and then a new impulse that gets generated. The steepness, how steep that 4 is, the steeper it is, the heart rate is faster. This is what you call normal automaticity. But sometimes you see here on the right side that this is what we call abnormal automaticity, is basically that phase 4 depolarizes slowly and starts generating even more and more and faster rhythms. The second mechanism is triggered activity. It is very much so similar to automaticity. It's a group of cells that generate an impulse that they're not supposed to generate. However, these cells typically respond to an external stimulus. So what you do is you put a catheter and you pace and you stop, and then you see that group of cells start firing right after you pace. So this is what we call triggered activity. So it's an automaticity that you enhanced by pacing, by stimulating that group of cells to generate that impulse. These are implicated in mechanisms that you might have heard of. There is the early after depolarizations for long QT syndrome. Long QT syndrome is the same. It's triggered activity that happens after a stimulus, external stimulus, similar to the digoxin toxicities, calcium overload, and so forth. And finally, and I want to spend some time on this one, is re-entry. Re-entry, it is the most common mechanism that we see in arrhythmias. I just ablated someone, re-entry, a VT, and I'll show you an example. Re-entry occurs when a propagating impulse fails to die out after normal activation of the heart and persists to re-excite the heart after expiration of the refractory period. Great, what does that mean? To simplify it, imagine this square as a slab of muscle. Imagine the impulse starts on the left side and slowly tries to move to the right side. Now, if all the heart muscle is normal, we assume that the velocity of propagation is the same. So you're going to see the impulse start from the left, propagate slowly to the right, continues to propagate at the same speed because the whole muscle is normal, and the whole muscle finishes that impulse and is ready for the next impulse. Hence, it's very orderly, and the refractory period, all the cells reach the refractory period at the same time, and then they are all activated at the same time. They all finish activating at the same time. They're ready for the next impulse at the same time. That homogeneity of that cycle, that propagation, makes our heart a very stable organ, unless there's a heart attack, for example. So imagine someone had a heart attack. We represent this by a scar. So it leaves a scar on the heart. That scar is not totally dead. There is small sleeves of muscle inside that scar that is still alive. So if an impulse moves from the left to the right, it will go around that scar area. It will propagate at the normal speed. However, as the rest of the heart has already activated and finished, that little sleeve is still being activated at a much slower velocity. And now if it exits that scar at a time where the cells on the other end of the scar is ready to be activated again, it will generate another impulse. Hence, it will go around, goes around, goes around again, and now finds the entry again, correct? So now if that channel is beyond the refractoriness of itself, beyond refractoriness, and it's ready to be activated again, you get re-entry. It's a short circuit. And this is what most VTs on patients with structural heart disease, heart attacks or heart muscle disease, have that mechanism. The sources of energy we use are two main sources of energy in the EP lab. We use heat and cold. There are other sources that I can talk about too, but those are the two main prevalent ones. The heat obviously is RF, and then the cold is, we call it cryoablation. The principle for cryoablation is to extract heat from tissues to induce freezing enough to injure the tissue. The cryocatheter utilizes the circulation of a refrigerant, mostly nitrous-based refrigerant, such as nitrous oxide, in a closed loop. So it's under pressure, it goes to the tip, you release it, it expands. When it expands, it absorbs energy. When it absorbs energy, the tip of the catheter cools down to about minus 80 degrees, and it freezes the tissue that's in contact with. And that gas recirculates back through the catheter and gets thrown outside. So there is a new version of it. So there's a cryocatheter, which is just a catheter tip. The cryoballoon is instead a balloon that the refrigerant gets injected in a fan at about 30 degrees to the front, not right in the equator of it. It's to the bit to the front of it, where it creates a circle of freezing, basically. And that circle of freezing, you can imagine, we can put it in a vein. Here, we're showing you the pulmonic vein. This is the basis of AFib ablation, where we freeze the contour of the balloon, and the contour, the surrounding of the vein, gets frozen, and you isolate the vein electrically from the heart. And I'll show you more examples later. RF ablation is more heat. So what we do is we apply a high radiofrequency current to the tip of the catheter. The ground or the return patch would be a patch on the thigh of the patient or the liver of the patient. And then that circuit, we push a high radiofrequency current. That radiofrequency current transforms into heat at the part of the circuit that has the highest impedance, which is where the catheter touches the heart muscle. And then generates a lesion. So the basic principle of it, like I said, is to generate resistive heat and conductive heating. So there's two components to creating a lesion with RF. There is resistive heating that is basically generated by the current at the interface between the catheter and the tissue. And then conductive heating, that piece of tissue that got heated, conducts the heat down into the tissue to create a deeper lesion. Now, when we first started doing this, we were using catheters that are what we call non-irrigated catheters. It's a simple tip, simple piece of platinum. It goes to the tissue, you heat, and that's it. We had limitations with it. There's a lot of charring that can form on that tip because you're cooking tissue, basically. The other limitation we had is when you heat tissue, guess what happens to it? At first, the conductive property, so it conducts heat well in the very first few seconds. But then when the heat rises up to above 50 degrees in the tissue stops conducting heat anymore. So you can't form a bigger and bigger lesion. So what we had an idea is, first, why don't we make the tip larger? So it's surrounded by blood, it's a little bit irrigated, and we can deliver higher energy through that tip. We can go to 50 watt or 70 watts through a 8 millimeter catheter versus maximum 50 watts in the 4 millimeter catheter. It worked for a bit, but that wasn't enough still. The charring was still a problem. So what we did is, what they did is, they designed what we call as cool the catheter. Now, temperature is rising and rising. The generator sees that temperature rising and it stops delivering power. It says it's too much heat. I'm going to limit my power. So what you do is we put a circuit of fluid inside the tip to cool it off. So you keep the tip of the catheter cooled down so you're able to deliver more power into the tissue. But that's a little bit of cheating, isn't it? Now, so hence the other iterations. Now we created, because we still had the problem. So what they created now is holes in the catheter. That's what we call open irrigated catheter. Now we're pumping fluid in the catheter, but that fluid is coming off of the tip of the catheter. It doesn't just cool the tip this time. It also cools the surrounding of the tissue that you're in contact with. And by doing that, you will drive the heat down, so you'll create a more concise lesion, but deeper lesion compared to non-irrigated catheters. And now, because we want to go faster in the EP lab, there are multi-electrode bipolar RF delivery catheters where you're able to deliver RF not just from the tip of the catheter, from multiple electrodes on the catheter, and we'll show some examples. So this is an example of catheter irrigation, how it works. So basically, this in blue, this line here is the 50 degrees isotherm of a reversible tissue injury, meaning that when you heat the tissue to 50 degrees, this is when you create an irreversible tissue injury. You kill tissue at 50 degrees. At 45 degrees, you can create what we call reversible, meaning you can heat it, it will stop functioning for a bit, but it has the power to heal and come back. That's why we want to reach the 50 degrees. So those two are the biggest thing This is no tip cooling in that curve, and this is the tip cooling. As you can see, the no tip cooling, you will reach higher temperature, but there's a stop to it. Once you reach that temperature, you can't drive more temperature deep into the tissue. With an irrigated, mostly open irrigated catheter, you're cooling the surface of the tissue. You're able to drive more power into the tissue, but because you're cooling the very surface, that temperature, maximum heat, will be reached within a millimeter under the surface of the tissue, not right at the interface. You see this is the distance from RF source, this is the depth. The non-irrigated catheter will reach highest within microns of the tissue contact interface. But an irrigated catheter is going to be able to drive the maximum temperature deeper into the tissue, creating a deeper lesion. Now, after irrigation came more and more advancement to the RF catheter. Now we have not just the irrigated tip. Now there are multiple holes to uniformly irrigate the tip of the catheter and the surrounding tissue rather than just 6 holes, up to 64 holes on a tip. That's what we call surround flow catheters. The tip also has an integrated pressure sensor and directionality sensor. So it's a coil that tells you how much grammage you're pushing on the tissue, and not only that, which direction. You can be pushing on this side, and there is an arrow that shows you the force going this side. The same, if you're pushing straight, it will show you a directionality of force that you're going straight at the tip. So there is a lot of advancements that happen to the catheter. One other advancement, obviously, is the location sensors. So now there's a magnetic sensor at the tip that tells you where the catheter is based on the magnetic field. So you put the patient with a magnet behind them, and you can move that catheter inside the heart without using X-ray. The machine or the mapping system tells you exactly where that catheter is and where you've been. And that's due to that magnetic chip at the tip of the catheter. And finally, I want to touch on pulse field ablation as a brand new field. It's not that new, but it's getting to being used in EP more and more. We have a session tomorrow about that. So PFA is a non-thermal energy that uses strains of high voltage, very short duration pulses to create microscopic holes in the cell membranes, a process called electroporation. When you make these cell membranes permeable, you lose the membrane potential, and the goal is to make these cells die by using this high frequency, high voltage, short duration impulses. The cardiac myocytes are among the most, they have the lowest threshold to these fields, so they are more sensitive than other tissues. Hence, it makes the myocardium a more tissue-specific delivery for PFA. Meaning, if I put a PFA in the atrium and I deliver, the atrial cells are more sensitive to PFA, let's say, than the esophagus, which sits right behind the left atrium. So the thought is we can injure the tissue, the myocardial tissue, without injuring the esophagus behind it. So it's what we call a tissue-specific energy delivery. The electrical fields, like I said, create pores within the cardiac myocytes in a selective and tissue-specific way, hence reducing the risk of the surrounding non-cardiac tissue. It's not like heat, where heat doesn't care. It's going to conduct through whatever tissue you give it in front of it. It goes through the wall of the atrium. It can go through the esophagus and wherever you put it, or through the phrenic nerve, for example. So this is where PFA has the upper hand. So these are the biggest 3 sources of delivery, for example. This is RF, which we tackled, which uses heat, and we go point by point and create a circle around the pulmonic vein to isolate it electrically. The other source is cryoablation, which we just explained, where we put a balloon and we inject the refrigerant on the surrounding in a circular fashion of the balloon, and it will isolate the vein or freeze the vein in a circular fashion. And finally, there's this one of the first catheters is a PFA catheter. It's like small halos that go around and they have electrodes on them, and you can deliver. It is the most contact permissive technique. So you don't have to be pushing to deliver the energy, whether it's heat or cold. You have to be at reasonable contact proximity of the tissue to be able to deliver, to create lesions. And it's been shown, multiple studies shown radiofrequency ablation can isolate veins acutely up to about 90% of the time. The cryo balloon, because it was designed specifically for segmental isolation of the pulmonic veins, also reaches about 90 degrees. The one study so far, actually there are more studies that are coming out, but the earliest study here showed about close to 100% of first try isolation of the veins in an AFib ablation. So this is a promising energy. And there's a lot to be discovered about it. There are multiple waveforms that you can deliver. There are multiple frequencies you can deliver. There are multiple pulse widths you can deliver or pulse times you can deliver. And in general, when you're using a pulse duration of milliseconds, you're generating a little bit more heat on top of just electroporation. The nanoseconds, it's the least heat, but the most organelle injury. So you're doing true electroporation with nanoseconds and milliseconds. So I'm not gonna go over all these right now. There's a session, like I said, about it tomorrow, but there's a ton to be learned as far as how much pulse duration to deliver, how much frequency, what voltage to deliver, what waveform to use. So there's plenty to learn still in PFA. This is the EP lab where we do EP study. As you can see, the screens in the control room, and inside the room there is this bed. I just was exactly in that room right now today doing a procedure. So we have screens. We have multiple screens on that big screen where we see the mapping system, X-ray. There is no integration happening now where we'll see if we get it at some point, where you wear like a halo around you, and it's like virtual screen around you where you can use your hand to move screens in front of you. You don't actually need that big screen. You can see everything in that headset. There are many companies now working on that. So I'll start giving you examples of ablations, and we'll talk about what kind of mapping we do, and hopefully this will help you understand what we do in the EP lab and what we might need. So there are multiple tachycardias. I'm going to show you multiple types of tachycardias. Each of them have a different mechanism, and each of them has impact on how we map it. I'll start with focal atrial tachycardia. It's the most simple. It's basically an atrial activation starting from a spot in the heart, small group that generates an impulse, and that impulse travels out in a centrifugal way from spot and out. So what we do is, this is what you see here on the right-hand side. It's called an activation map. An activation map is, I go in, I put the catheter in multiple spots. Do you see these little white dots? These are multiple spots that I go in and measure the electrogram. And what we do is we pick a reference. Let's say the coronary sinus catheter, which you can see here in blue. I pick, let's say, these two dipoles as a reference. I put it in the middle of a window, and I color code time to that reference. So the earlier I am, the more red I'm going to be. And you're going to see that map change as we go, because you're going to see an earlier spot, and yet an earlier spot. I'm going to say an earlier spot. And as you go earlier, that red is going to move with you to the earliest. And when you map the whole chamber, you can see that if you color code time, you'll see, oh, I have an early generation of impulse right there. So this is the tricuspid valve. This is the SVC and IVC here. This is the coronary sinus. And around the His signal, there's a blotch of red. Most things are coming from there. Now, it's dangerous to ablate there because you're next to the His. You can give the patient AV block and end up with a pacemaker, especially if you're young. You don't want to commit the patient to a pacemaker for the rest of their life. Well, there's an adjacent structure, and the blotch of red is big, so there's a lot of early spots. When you have more than one early spot, that means there's still one earlier than all of them, always. So we went to the aortic valve, which sits right facing that. And this is an audio and LEO view. This is the fluoroscopy. The His is usually located right here between the non-coronary cusp and the right coronary cusp. This is the non-coronary cusp. This is the right coronary cusp and left coronary cusp of the aorta. And the His usually sits right here. So if you go around the His here in the non-coronary cusp, you are facing that on the other side of the septum. And you'll see in the 3D mapping system. So here the ablation is now in the aortic root, in the aortic valve. I'm mapping the spots again for the aorta. And then I managed to see this, little tiny. This is what you want to see, this one little tiny spot that's earliest than all of them. Now, watch how the red was here, moved to that spot because it was earlier than all of them. And we deliver, as you see here, ablation on. And within 2 seconds, the tachycardia terminates into regular rhythm. So this is the tachycardia running. And you see here the high right atrial signals, mostly A's and sitting in the RA. The His signals, which show you an A and a V and a His signal. And this is the coronary sinus, where it has 10 dipoles. We measure these signals basically between 2 dipoles. We call it 1 and 2, 3, 4, 5, 6, 7, 8, 9, 10. So each of these signals is generated. It's a bipolar signal measured between those 2 dipoles that you see on the coronary sinus. You'll see more examples of that. Now, another type of atrial arrhythmia, typical atrial flutter. When you hear that word, we call it typical atrial flutter because most of us now know where it is at. So if I go in and I've seen it on the EKG, I know exactly where to ablate because they all go through the same isthmus. They all use the same way to generate themselves. So a typical flutter is most common to describe a micro reentrant. So this is a reentry, so it's a cycle. So there's no early here. Every time you're going to find something earlier and earlier. It's a continuous wave. And I'll show you a video of that. It'll explain it more. So what happens is it goes around the tricuspid valve in this fashion, either clockwise or counterclockwise. And usually, if you ablate that tissue between the tricuspid valve and the IVC, you'll break that circuit, and you'll inhibit that flutter for a long period of time. You can actually cure it in about 95% of the time. So this is an example of a flutter. Sawtooth on the EKG, when you see it like this or like this, that's what we call typical atrial flutter, and it's usually counterclockwise. Now, when we measure time, so what you see here is 2 views of the right atrium activation map. So we color-coded time to a reference. So I pick a reference, and everything early will be coded in green, yellow, and red. Everything after that reference will be coded light blue, blue, purple. Here what you see is what we see early meets late. The earliest spot is meeting the latest spot. Why? Because you chose a window. Everything behind that reference goes to purple, and then when it jumps to the next window, the computer is going to say, oh, it's early on my window, so I'm going to code it red. Why? Because this thing is moving all the time. It's not starting from a spot and generating out. It keeps rotating. Hence, your early, the tail of the wavefront was going to meet the late end of the wavefront, and it's going to continue. Here is the isthmus. So this is the IVC. This is the tricuspid valve. As you can see, it needs that area to sustain itself. If you draw a line between here and here, you're going to break that circuit. It can't rotate anymore. Hence, you can cure that flutter. So let's see here if I can play it. This will explain to you. Now, what we do is we call the propagation map. So what happens is now I'm playing time. I'm playing the signals in time. And it will be surrounding, rotating, counterclockwise to the side, and starts again, and rotates again, and keeps rotating. Imagine this playing over and over. So that's your flutter. So what we do to ablate it is to go, like I said, into the IVC, start the ablation with the catheter, whether we can use cryo or RF. RF is much faster. Cryo, you need a long time to apply per each point. But you draw a line between the tricuspid and the IVC to break that flutter. And as we're doing, you see the flutter going, and it breaks as we apply RF when you finish that line, and this patient switched to an atrially paced rhythm. So this is the flutter recorded on the coronary sinus. Atypical flutter is the same principle, but this time we don't know where the isthmus is. Typical, you know you're going to go to the IVC. Atypical is it could be anywhere. It could be related to a scar. It could be related to the mitral valve, an anatomical barrier, or a barrier created by a surgeon a few years ago. So it usually is due to atrial macro-reentry. It's same thing. It comprises of a heterogeneous group of arrhythmias that can arise from both the right and left atrium. And in many cases, these arrhythmias sometimes coexist with atrial flutter. This is a lung transplant patients. So what you're seeing here is we went to the left atrium. This is the mitral valve. This is the map of the left atrium. You see these kind of weird-looking pulmonic veins. That's because when they hook the lung transplant to the new heart, so when they bring the new lung from the donor to the heart, they don't hook them vein to vein because those veins are small. If you suture them vein to vein, they're going to stenose. So what they do is they take a cuff. They cut the cuff, so they cut them both together with the cuff of the atrium, and they hook them to the recipient atrium, cuff to cuff, not vein to vein, to make it bigger. So even if it narrows down, it doesn't constrict and close the vein down. And what we found is because they do a lot of cutting and suturing here, there is a small area, like I showed you before, of scar that conducts extremely slowly. As you can see, this is a proof of it conducting slowly. This electrical current is traveling under the catheter here for about 150 milliseconds and comes out. Comes in and comes out. So that is the slow part of your circuit, and that's usually your isthmus. And once you figure that out, so your circuit is going around the vein, going down, behind, again, the slow part going up, and then rotation, slow rotation. So once you figure out where that slow isthmus is, you can see it here right under the catheter. You see that each revolution of the flutter, this thing activates over 125 milliseconds and then exits, generates the flutter, and then activates, generates the flutter and activates. So what we do is we burn right there. That's your isthmus, the circuit. And as you're burning, the beautiful thing, do you see that? Long fractionation, and fractionation cut by half. So now, and burned it. It did not continue. It broke the tachycardia, and you're out of the flutter. Again, this is our goal, is to ablate that isthmus. And you'll see, actually, the beautiful case, this nice thing about this case is you see the actual long fractionation cut by half. You broke it right in half. And then when you broke it, as soon as you broke it, the flutter ceases to exist. So that's proof that you're right on the spot, and that was the isthmus. There are other tachycardias that we also that ablate on a normal heart. So AV-NRT, if you hear AV-NRT or SVT ablation, is one of the SVTs. AV-NRT is a short circuit that happens inside the heart too, but you don't have to have surgery before. It happens on a normal heart for reasons that we don't entirely know. A lot of us, the AV node has a fast pathway and a slow pathway. They work together to compensate for each other. A lot of us, if you catch people from the street, a lot of us have dual AV nodal physiology, probably about a third of us, a little bit more, about 40%. But not all of us have AV-NRT. The electrical properties of these two pathways of the AV node have to intersect in such a way to provide a short circuit for it to happen, to give you an SVT. So this is what we call the fast pathway. Usually it's behind the tendon of Todaro, and the slow pathway, or rightward inferior extension, which is in front of the coronary sinus. The compact AV node is sitting in the triangle of Koch, and this is the His bundle right there. In the older days, they used to ablate this part to break the SVT and cure it. But you get AV block in 50% of the time, and you give the patient a pacemaker for the rest of your life, and those patients are usually pretty young. So it changes their life. A guy in Oklahoma City figured that out for us, that, hey, what if I ablate the slow pathway here? They figured that there is a slow pathway, and we can ablate it right in front of the CS. Now you can cure AV-NRT with an ablation when you do it there, in about 95% of the time, with risk of AV block of less than 1%. And so this is, again, the picture to explain to you how the AV-NRT happens. It's a short circuit that goes up the slow pathway. Usually they work together in the same direction, but this one, it can cause a short circuit and rotate around the coronary sinus. It goes up and rotates around. And once you have that short circuit like this, you have SVT. The same, this is an LAO view of it. Rightward extension, up the AV node, the fast pathway, back around, and re-enters here, and then you have an extremely fast circuit because it's a small area that's activating around. And this is how it looks usually on EKG. I'll show you. But the goal is to, like I said, is to ablate the slow pathway right here. We used to do that, high degree of AV block. Now it's less than 1%. And this is what you get, a schematic view of AV-NRT, short circuit in the middle. But because when you have this, you get activation of the atrium and the ventricle at the same time. So when you look at an EKG, the P wave and the QRS are on top of each other, so you don't see P waves. Hence, we call it short RP tachycardia or SVT. And this is an example. Actually, you can see the P wave right here at the end of the QRS, at every end of the QRS. You compare it to the sinus QRS, you won't find that little depression at the end because that's the P wave sitting right on top of the QRS. And now, another type of SVT is called AVRTs. So instead of having two pathways inside the AV node, there is what we call an accessory pathway independent away from the AV node. So this is your AV node, His bundle, right bundle, left bundle. And what happens in AVRT or an SVT related to WPW syndrome is the pulse goes down the AV node. It's supposed to die there, waiting for the next sinus beat to come down the AV node and activate the heart. In this situation, because you have the extra connection between upper and lower chambers of the heart, that impulse finds a way to travel back up, activates the atrium, goes back down the AV node, and hence you have a short circuit. That circuit can be the opposite way, can go up the AV node, come back down the pathway. When that happens, it looks ugly. It doesn't look narrow. It looks like a VT. This is the circuit. This is the most common circuit. Out, down the AV node, up the pathway, and down the AV node. This is, again, what you see when you have very similar, but the P wave is a little bit out of the QRS. In general, in AV NRT, you'll see it a little bit out of the QRS. We call it intermediate RP tachycardia. And you see these P waves right here, a little bit outside the QRS. They tend to be fast, too. And the way we do this is the tachycardia that you're seeing here. Up the pathway, down the AV node, that gives you a narrow complex tachycardia. Now this is a different story. It's wide, it's ugly, it looks like a VT. This is actually the opposite circuit. You're going up the AV node, going down the pathway. When you're going down the pathway, it will give you like, it's very similar to putting a catheter inside the RV and pacing it very fast. So this is an example now of an AVRT that we mapped. Now what we did is we mapped the earliest activation. So remember, it's going down the AV node, coming back up the pathway to the atrium. If I look at the earliest atrial activation, I know this is where the pathway inserts itself to activate the atrium. So what we do again, we pick a reference, and we go around and we look at our earliest atrial activation during the SVT. And when you find the earliest activation, this is the atrial mouth of that sleeve of muscle of the accessory pathway. And by locating it, you can deliver RF there, ablate the pathway, and you can cure this rhythm from happening again. Like we said, coming down the ventricle. So this is, like I said, going down the AV node, which is usually here, the AV node, going up the pathway, which we found to be here. And we delivered these three little dots. You see them? Those are 3 RF lesions that cures this pathway. And as you can see here, we broke the SVT. It continued to be still excited. We call it pre-excited. So sinus node, AV node, and pathway. So the sinus node is still activating both, hence that slurred QRS. And here you notice here at the end, the QRS became narrow. I took away the pathway. Now the sinus node, here the sinus node is activating only down the AV node, and it's not coming down the pathway anymore because I just ablated it. So it went from this slurred to this narrow, thin QRS, only AV node activation. Okay. Now the AFib. This is where technology becomes heavier and heavier as we go. AFib is the most boring ablation we do because it's completely anatomical. My fellows just told me like I light up during a VT ablation because I try to figure out circuits, and it could be anywhere, and it's like a mystery that you're trying to solve. AFib ablation, you walk in, is like, yeah, sure, let's just go and do it. That's unfortunately because we still don't know enough about AFib. We need to know more about it. We discovered something in 1997 that told us, oh, go after the pulmonic veins, and what's what we do today. We haven't really made big strides yet, I hope, big strides in understanding it more. So AFib is a chaotic and fast atrial activity resulting in disorganized atrial rhythm with an irregular ventricular rate. It's the most prevalent cardiac arrhythmia. It's the most frequent that you're going to see, 2% of the general population, and increases with age. So as you have an aging population, you're going to see more and more of AFib. It can cause palpitations, reduced exercise tolerance. It can actually cause strokes because it can increase your thromboembolic formation, and you can cause a clot, and it can go and can cause a stroke. The most common trigger currently studied is the pulmonic vein. It's a Michel Hazeguer paper, New England Journal of Medicine, 1997. I still have the picture in my head. He and a group of people, I actually work with the son of on the EV-ICD, with the son of Jacques Clémenty, who was a senior author on that paper. I work with Nicolas Clémenty, who's one of his two sons on the EV-ICD project. So they figured out that the trigger that starts the AFib is most of the time sitting in the pulmonic veins. Usually you have two of them coming from the right lung and two of them coming from the left lung. So what they did at first, they went in and burned those triggers in the pulmonic veins. And they said, okay, we're gonna just get rid of those triggers in the veins. What they realized later is if you burn too much in the vein, those veins are small and they can collapse because of the inflammation. So another guy, Italian guy called Paponi in Italy, figured it out for that. He said, okay, if instead of going in, what I'm gonna do is I'm gonna ablate around the veins in a circular fashion to isolate the veins electrically from the heart, but without burning the actual triggers. The actual triggers are alive, and they still fire in the vein, but they don't get to the heart anymore, and they don't cause AFib. And that's what we use today. We're called WACA, Wide Area Circumferential Ablation, and I'll show an example. So this is what AFib looks like, totally disorganized baseline. There's no P waves here. You can see this little wiggly stuff in the EKG. And what we do for pulmonic vein isolation is we put a lasso catheter inside the vein, and we go around the vein. Now, we don't go this here, but we go all around both veins at the same time. As you can see here, this is not the nicest one. It's with the old system. I still have it here with me, use it. Usually the lines now with the newer technology are much nicer and much tighter. And what we do is we do this around each set of veins. And our goal is to isolate those veins electrically from the heart. And the way you see it is you put the lasso here, and this is, you can see lasso. Now we use another type called Pentaray, and, or other multi-electrodes. Here is like 1920, 17, 18, 15. These are the little dipoles recording. Those are the bipolar recordings from inside that lasso between each two dipoles. As you can see, during AFib is just going, disorganized. And as we close that circle around the veins, you see these signals disappear and boop, all gone. This is what you call an entry block. So there's still AFib, the atrium is still in AFib, but now the vein is completely isolated. Now what you do is you isolate both veins. You do it on the other side. This is the right veins, the same, isolated. And then you can shock the patient out if they're in persistent AFib. Now you don't have triggers. You took away the triggers. Now even if firing happens in the veins, the rest of the atrium doesn't necessarily go into AFib. We've had the opposite happen where we're ablating. Instead, we see the atrium go into sinus rhythm, but the vein is in AFib, and it stays on its own. I have an example of that. I'll show it one day, but I keep it with me. I'll show it. It's rare to see that, but you still can see it, where the veins are still in AFib, still trying to put the rest of the atrium in AFib, but because you lock that line around it, there's no more AFib going on in the atrium. Now, there are multiple technologies to speed that process, because instead of doing it point by point, you can use this multi-electrode that you can apply RF from all of them at the same time. You rotate it, you apply again. There are balloons. We're going to talk about it tomorrow again. Also, there is a balloon that delivers RF. You deliver, you rotate, you deliver, you cover the entire circle around the vein, like helio balloon and so forth. And there are multiple shapes of multi-electrode catheters, as you can see here, to deliver multiple lesions at the same time. The cryo balloon we talked about, where it delivers it injects that refrigerant into that balloon in a circular fashion to create a circular freezing lesion to isolate the vein. And you have usually a catheter here sitting, and you'll see the same. As I showed you on RF, those signals simply suddenly go away all at the same time. Now, the razor balloon is another. Those are 3 FDA-approved catheters, by the way. This one did not gain a lot of traction because the catheter is big to deliver. But this is a smart idea. So what you do is you put the balloon inside the vein right here. You inflate it, so you're now looking at the edges of the vein. So this is the catheter going inside the vein, and you can see here the tissue. So this rim is basically this rim of the vein. And what you do, you see that laser? Deliver laser burn. You move it, So it goes here, you move it down, and you deliver laser. You move it here, deliver laser, deliver, and until you deliver the entire circuit. So that's a laser that moves, and you can do the whole circuit under direct visualization. It's a cool technology. The reason is they haven't been able to shrink it down because it's a 17 French to put it through the fossa and do it. It's just a higher risk of bleeding, higher risk of damaging the heart. That's why I didn't gain a lot of traction, but some centers still do it. We don't do it. We chose not to because I think there are a little bit safer techniques to do. Now, ventricular arrhythmias, PVCs. So those are the same like an ATAC, so focal arrhythmia, but coming from the upper chamber of the heart. This is a focal arrhythmia coming from the lower chamber of the heart. It just fires. It's a group of cells that fires without rhyme or reason. It usually is benign, but can be associated with palpitations, waking patients up at night, can cause LV dysfunction. So this is an example of a 55-year-old gentleman with history of CAD. He's got palpitations and fatigue, and his EF is 40 to 45%. We checked his vessels to see to explain the low heart function, and we couldn't because the stent is still open. He doesn't have stents, but his CAD is not significant enough that caused the low heart function. He had 22% PVC burden. We could not explain the low EF by anything else. It's an exclusion diagnosis. Hence, we suspected PVC-induced cardiomyopathy, and we went after the PVC. So this is the PVC that you can see right here, the extra bead that looks different than the rest of the EKG. So this is what we call, remember, an activation map. So this turns out to be in the aortic valve. This is the right coronary cusp, non-coronary cusp, and left coronary cusp. And what we're looking for is the earliest spot and also this. So this is to tackle another piece of mapping that we do. So you see this little edge, it's the earliest. It's ahead of the QRS, ahead of the whole QRS. And these two are what we call unipolar mapping. Unipolar mapping is basically I'm taking the signal, not between the two dipoles, 1 and 2, 3 and 4 of the catheter. I'm taking the activation between the tip of the catheter and a patch on the thigh of the patient. So basically anywhere, any signal. So your source, the source of the arrhythmia, should show you a totally negative unipolar. Why? Because if you're sitting at the source, the signal can only be away from you towards that patch, if you're at the source. If you're not at the source of the arrhythmia, you still can catch something coming towards you before it goes away from you. Am I making sense? If you're sitting at the source, there could not be a wave coming towards you. Because you're sitting at the source that's generating the wave, it has to go away from you in all directions. Hence, you're going to see this little dip. If you're sitting at an isolated small amount of tissue in a big fibrous body, and it exits into the myocardium, it generates a little unipolar negative and then a big one. And these are the PVCs, a little, big one. I keep this and showing it to fellows because this is the dream when you're looking for PVC. This is the dream signal you look for to ablate. And this is you go there and one ablation, you get rid of the PVC and you go on. Again, we look for the earliest spot, the unipolar, a little bit of negative, and then a strong negative after that. No positive forces on your unipolar at all. And then the same here we call pace mapping. Now you look, you sit on the source, and I say, okay, let me confirm I'm on it. I'm going to pace from that spot and see if the QRS that I generate is similar to the PVC that I'm after. Usually use that technique if you're not having a lot of PVCs and you want to confirm your location. You don't use it on everyone, just when you have a lower number of PVCs, because when you have a lot of PVCs, you look at timing. That's your best. But sometimes we use this technique, and look at this, for example. We pace from that spot, and the QRS we generate by pacing is exactly the same on every level, on every lead, like the PVC that we're going after. That confirms you're on the spot. So again, aortic valve, we shoot an aortogram to make sure that we're away from the vessels because you don't want to take the PVC away and give the guy a heart attack. It's not a good exchange. And then we deliver energy, ablation off, and no PVCs whatsoever after that. And finally, VT. This is a case I was doing right now. So VT is a tachycardia originating from the ventricles. It can have two main mechanisms. In normal hearts, it could be automatic. It could be a spot, but instead of generating a PVC at a time, that's a spot that does this. Boop, 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 stop. Boop, 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 stop. It goes by salvos. That's what we call automatic VT. It's usually benign. It causes symptoms, but it typically does not kill anyone, typically. So we don't give those patients any ICDs or defibrillators. On the other hand, when you have structural heart disease, when you have someone who had previous heart attack and you see a VT that sustains itself and stops, typically those VTs can cause sudden cardiac death. And it's not enough to get rid of the PVCs of the VT in those patients. You have to give them a defibrillator to prevent sudden cardiac death down the road. So that's the difference between a structurally normal heart and a structural heart disease, someone with structural heart disease. And this is what a VT looks like, very ugly, wide. You don't want to see this. And the three maps that we do is, first, activation mapping. If you go in and we did that today, if you go in and you're part of that 10% of patients where I can put you in the VT and you're stable in it, then I have time to go around and map to figure out where it's coming from, figure out where that isthmus is, and burn it. It could be anywhere in the heart. Sometimes it hides very well, like today. But with some diligence, you'll figure it out and ablate it and get rid of it. Now, when you can't, when you induce the VT and the patient crashes, so you induce a VT at 220 beats per minute and you're under general anesthesia and the patient is unstable, you don't have 10 to 20 minutes of cardiac arrest to map the VT. You stop, you shock the patient out, you go around, pace around in the scar to figure out where it's coming from, and you do what we call like a snap approach where, now I think it's coming from there, I'm going to induce the VT and I'm going to use about 30 seconds of cardiac arrest to go around it fast and figure it out, and then you stop it again, have the patient recover, you induce it again, now ready to ablate, and ablate it and see it go away. So it's a pretty good technique, but obviously you can't use it all the time if the patient is not very stable. And finally, there are sometimes PVCs that can trigger VF, and that's a whole separate discussion. But you ablate the PVC that triggers the VF, but that's rare. So this is an example of a 60-year-old woman with history of an inferior MI, EF of 40%. She has a history of recurrent VT. She got ablated multiple times, and she keeps recurring. So they referred her to us to say, hey, can we fix this VT? And so we go to the lab. Here you can see me pacing. I use this pacing technique to trigger the VT. So I say, okay, VT at 160 beats per minute or so. She's stable. I have time to map. I'm showing you the 10% or 15% of patients. So we go around and we build what we call the activation map. So I choose a part of the QRS that's my reference. Everything ahead of that reference is in red. Everything after that is in purple. And what did we say about VTs in structural heart disease? They are reentrant, like that slab that I showed you in the beginning of the presentation. There's the circuit that goes. Your job is to figure out where that little sleeve of muscle is that's slow. And you can see here, early meets late. So kicks it out here, goes around, and goes in. The same here, goes around and goes. Why? Because this is red, yellow, green, light blue, dark blue, purple. Red, yellow, so it's rotating. And I flipped this picture on purpose for you guys to show you exactly how the isthmus is. There's a big scar. So, this is a voltage map. What does voltage map mean? Instead of color coding time, I'm color coding the local voltage at each point. Obviously, if the voltage is very low, that's dead tissue, that's scar. Voltage is very high, that's good, healthy tissue. So what we do here, if you look at this, everything below 0.5 millivolts is in red. Everything above 1.5 millivolts is purple. And everything in between is in between. So you can see here a big blotch of red. That's a huge scar caused by the inferior heart attack in that patient. And you see this in the middle of the scar here, right here. There is this little circuit that goes like this, like a figure of 8. I don't know if I have the video for that. I hope I do. Yeah, there it is. Beautiful. So look at the propagation map, how the VT circuit is doing. Do you see that? So it's entering in that slow. There's a slow conduction, exits in that red, and it goes around. Usually I like to show these videos because they truly show the re-entry for the VT. It makes people understand it better. Okay? So a little bit faster. Is that the fastest? I should probably cut. Oh, no. Okay. So this is in real life what's going on electrically. So they slow with it to show you what the circuit is. but the VT is going. When you see that VT, with every heartbeat, there's a full revolution of that map that you did. Okay, so here we do ablation, and we see it terminate about a few seconds after the start of the ablation. Now, some circuits, though, this is a circuit that we saw on the inside of the heart, and RF usually typically can cause a lesion that's about 3 to 4 millimeters deep. You can't go more than that. You can't deliver deeper energy than that. There is a catheter that's called the needle catheter that has a needle that comes out of the tip, and it has holes on the sides, and you can irrigate the needle and deliver. It's pretty aggressive. They took it off the market because not everyone can handle that tool. It can kill patients. So I wish they have it, because there are sometimes circuits that are deeper in the muscle. You can't reach them. They are 5 millimeters, 6 millimeters deep, and you can't reach them. You can ablate them with RF. Sometimes they're all the way on the outside of the heart, and this puts you at about a centimeter away from your catheter if you're on the inside of the heart. So we do what we call epicardial ablation. So instead of going through the groin to the inside of the heart, we go through the subxiphoid area to the pericardium. So the heart's sitting in the pericardium, in a bag. So what we do is we access that bag, we put a thin wire, make sure we're on the outside of the heart, not through the heart. We put a bigger tube, and we have a catheter that can go around the heart now and map the outside of the heart without opening the chest. In the older days, they only could open the chest to do these things. Now we can do it percutaneously through a small puncture here under the xiphoid. And this is what we do. We pass a wire here. You can see the wire going up. I injected some contrast to make sure I'm in the pericardium, and I push the wire, a lot of wire, to make sure it's going all around the heart. If it doesn't go all around the heart, that means you're in the RV or in a chamber. You don't want to dilate. You need to pull that wire out. So, and then what we do is through that wire, we put a tube and then sheath, and then the catheter can go all around the heart and map the outside of the heart. That's what we call epicardial ablation. Obviously, when you ablate on the epicardium, what's on the epicardium? The phrenic nerve, you don't want to injure it. And coronary arteries, you don't want to cause heart attacks because they sit on the outside. You don't want to burn a coronary artery. So we do angiograms to make sure we're away, which what we did today too. So this is an example of a 65-year-old guy. He has a non-ischemic. So these scars are really hard. They're not usually on the inside of the heart. They're on the outside of the heart. That's the peak of VT ablation, is non-ischemic VT. His EF is 30%. He has already an ICD. He had recurrent VTs. He had 5 previous endocardial ablations in a matter of a year and a half, 5 of them, and he keeps recurring. He was referred actually to us to transplant him, to give him a heart transplant. His heart function is okay. He's not in heart failure. He's got all these circuits that keep causing trouble. So instead, we decided, so they called me and they said, can we attempt to fix these before we transplanted him? Because the transplant is a big deal. You start a timer once you have a heart. You've got 10 to 15 years on your life and you're done. Now, he's 65. You can say 10 to 15 years is pretty good for him. But if someone who was 55 or 50, you're shortening their life if you transplant them early. So you want to make sure that you do everything you can before you give them a transplant. So what we did is we went on the surface of the heart. We knew that on the inside, we mapped briefly on the inside. We knew that this is not going to be on the inside. Instead, we did that puncture, and we went on the outside of the heart. Now, this shell is a voltage map of the surface of the heart. This is the bottom, the inferior part of the heart. Oh. And what we did is we did an activation map of the first VT. So I think it was a 12-hour procedure. I'm here early. So it was a 12-hour procedure, and we did 13 VTs, 13 circuits. But this is the main ones, and I'll show you each one of them. So this is the circuit. I showed you the activation. Comes out of the green. So there is an isthmus somewhere here between this and this. That's very small, and we didn't pick up, but it's sitting there. So it's rotating around and in, around and in. And what we did is we ablated that first circuit right there. So we ablated this amount of tissue between those two inside the scar. He gave us another VT, which was the opposite of that one. So this one, instead of exiting down and going up, this one is exiting up and going around. So that same funnel tissue, you can take it in both ways. The same with the third one. This is yet another one. This one is sitting on the bottom of the heart, not on the side of the heart, but at the bottom again. So you can tell here, there's a funnel that the activation goes through and breaks out and causes the VT. So I ablated this right here, which is this tissue right there. They're synced. Those two the voltage map is scar map, activation map is on the left. And then the last one, another example. You see that? Breaks out, goes around, comes back in, breaks out. So the isthmus was right here, which sits right there on this map. So I ablated all these circuits. 2 years out, he's no VTs, no heart transplant, he's sitting at home. So this is sometimes like being diligent with these VTs or with these circuits and knowing exactly the mechanism and using the best tools will get you results like that. So with this, I'll conclude my presentation. Thank you very much.
Well, that was great. You really explained all these complex arrhythmias to a great degree, and more I hear it, more I start understanding it, and the pictures are really nice. You know, you showed us a lot of the maps and everything else. I think these are like Cardo maps that you're using.
Yes. There are other mapping systems we use. The Carto mapping is magnetic based. We used to have a completely electrical impedance based system, which is basically measures the electrical impedance between the tip of the catheter. The nice thing about that system is you can use any catheter, even without a magnetic tip at it, and that system can calculate where their catheter is. So you don't need proprietary catheters to use with that specific system. So you can use any catheter from anyone, and it will locate it. It wasn't as accurate, though. The second iteration of the ASI system, they combined electrical and magnetic impedance, and it became really, really good. And there are other ones, too. I think Medtronic has one now.
So, question.
Thank you for your presentation. You mentioned that mainly you're using the RF ablation technique because the cryotherapy took too long.
Yes.
Is there a reason that you chose RF over pulse field ablation?
Yes. So first of all, pulse field is still in trials. It's coming out soon in practice, and we're hoping to get it. But it's still under trials, and the trials are just coming out now. That's why we did not choose. It's not we chose. I would love to use that technology. Plus, in the last few years, there's a lot of advancement to use which waveform, which pulse width, which pulse length, which pulse form wavefront to use. So there's a lot of advancement came with using that to see whether we want to minimize the heat, the resistive heating, and we want to maximize the electroporation. There's actually catheters now that are being designed that can deliver both RF and and PFA. You can switch generators and use the same catheter to deliver both. They're about to be on the market soon. For other systems, why also not cryo? I can ask why not cryo. Cryo takes about 4 minutes each application. Now we went down to 2 minutes with the newer balloons. But to do an isolation or to do an application with a single tip catheter, you need to freeze for 4 minutes, thaw, and then freeze. The freeze is not enough to form a lesion in cryo. You need to do that sequence, freeze, thaw, freeze. That's the full lesion. If you just freeze once and stop, you're not gonna get what you want. The tissue can regenerate. So for the balloons, it was 4 minutes of freeze, 2 minutes of thaw, 4 minutes of freeze for the cryo balloon. But it has a higher risk of injuring the phrenic nerve. And if you need anything besides a circular lesion, like the balloon, you need to open an RF catheter. You need to open a point-by-point catheter. So for economic reasons and for that, we did not use it heavily. We do have the technology. We can use it, but we don't use it as much.
Thanks for your talk. With the VT ablations, how many circuits do you typically find in a typical patient? And is there a concern that you're just going to keep finding these circuits?
Yes.
And okay.
Absolutely. So this is why a lot of people hate doing VT ablation, is because sometimes you go in and the scar is so big you keep going after a circuit and after a circuit. This guy had 13 of them. We rendered him non-inducible at the end, but we had 13 of them, but he was stable in all of them, most of them, not all of them. But we kept mapping until we made him non-inducible. There are patients that you go in and you see a VT and it switches within 5-10 seconds to another VT, yet another VT. And those are, we call degenerative VTs. You know that you're not going to get anywhere. You can ablate the clinical ones, and you're not going to get anywhere, and you stop, you say this is too advanced. So there are cases where we say we're not going to take this patient. But ischemic cardiomyopathy, to go back to the bigger picture, so someone with heart vessel disease had a heart attack before, he's having monomorphic, 1 VT that you see on his device, because the device gives you a tracing can to coil, so it's like in 1 lead EKG. So you can use that tracing to decide whether this is monomorphic or not. If you're giving you someone as just monomorphic VT, ablation is extremely effective in getting there. Sometimes, yes, you go in like today, the guy had 2 clinical VTs. That means with 2 VT circuits that we saw on his device that he's doing. He gave us 5. I went after the 5. Because studies have shown if you get the clinical VTs, you will decrease their chances of getting ICD shocks. If you can render them non-inducible, that's even better long term, but that also signals to you that that patient also has a higher survival rate down the road because they don't have a lot of VTs. It doesn't mean that we made them survive longer, but the fact that you can render them non-inducible, not just the clinical VT getting rid of it. You have random non-inducible with any VT, that also tells you that this patient has a good survival, long-term survival, not just avoiding ICD shocks. But yeah, there are times where once you hit 5, 6, 7 circuits, and the type of VT that you see will tell you that whether you're heading the wrong way or your efforts are futile.
Do you think you could comment on any like pre-procedural planning techniques, or
Yes.
if you have any
Absolutely.
that helps with mapping?
Yeah, great question. So I use MRI like the bread now. So every time we go for a VT ablation, I get an MRI because the MRI will tell you where your scar is, what you're dealing with. For 2 reasons. One, location. So once you see a scar, let's say I see a scar on the septum and I see a monomorphic VT, and there's no scar somewhere else, I know I'm going to go in and hone in on that area. So I'm not going to lose time or waste time on other areas. I'm going to build the map, go in, induce, and focus on that area because I knew this is coming from there. So now, 1, localization. Number 2 benefit is transmurality. Basically, so for someone who has had a heart attack, most of their circuits are on the inside of the heart. But studies have shown if you have a transmural lesion, the whole wall is scarred up on the MRI. There is a higher chance of these circuits being on the outside of the heart. So you prepare yourself. I'll tell my techs, hey, keep that area open for me. Don't put magnets there and patches there because I might have to go epicardial on this case. So that tells you whether you need epicardium or not. Number 3, gives you prognosis, the amount of scar that you're dealing with. If you go in on someone who has 2 or 3 VTs, like you said, but then the whole heart is scarred up everywhere, you know your prognosis is not going to be good. Your goal in that case is to go and get the clinical VT and get out because you're not going to render that patient non-inducible. You just want to decrease his ICD shocks until he gets a transplant. So you're bridging him to transplant. So for all these reasons, MRI for sure. For AFib, we do CT or MRI to get the anatomy of the pulmonic veins. Now, a lot of people don't use that these days anymore, or they use it just to bill for it, unfortunately. But I use it because I've been surprised where there's a vein that comes out from the roof into the left atrium, which is unusual. Or a big diverticulum that you can go into without knowing and you can cause a perforation. Most perforation in left atria during AFib ablation come from these diverticula. So I do CT scan or an MRI to get the anatomy of the left atrium. So I rely heavily on imaging in preparation of the procedure. For AFib ablations, we used to stop blood thinners and restart it. Nowadays, it is required that you keep it's the only procedure where you tell your patient, do not stop your Eliquis or your warfarin. Everyone says, really? No, all other surgery, I stop it. No. For this, I want it to be INR between 2 and 3. I want it to be blood thinned for this procedure because it takes the risk of stroke from 1.5% to less than 0.5%.
Question. What kind of percentage do you see scars on episurface, or you predict we'll see on the episurface?
Yes, great question. In an ischemic cardiomyopathy, so we have to differentiate between 2 things. So how many times do you see scar on the outside and how many times your circuit is on the outside? So you can see on the outside. So your circuit is in an ischemic cardiomyopathy, heart vessel disease. Your circuit is on the outside of the heart between 11 and 21%. I'm being precise because I just did the review about this, writing about ischemic cardiomyopathy epicardial ablation. So depending on the series you're seeing, Up to 21% of these circuits are in there, but the true number is really about 10% or 11%. How many have scar on the outside of the heart is about 30 to 35%, so way more who have scar on the outside. For non-ischemic, which is a different animal, your scar is very patchy and everywhere. Your circuit is on the mid-myocardium or outside the myocardium in 40 to 50% of the time. And if not the majority sometimes. Those are the patients we take for VT ablation. Some of them we know it's mid-myocardial and we give up and we don't take them. So those are not counted from your denominator in the studies we looked at. But I think it's at least 50%.
Does your 12 lead automatically detect the arrhythmia, and how accurate is it?
It detects the arrhythmia itself. Are you talking about location?
No, like what type of arrhythmia?
Yes, they are very reliable. So wide complex tachycardia tells you you're dealing with VT most of the time. So if even like the studies, some studies have shown that if someone calls you, an ED doc calls you and says, I have someone with wide complex tachycardia, you ask him one question, did he have a heart attack before? If he says yes, you can call it VT and you'll be right in 84% of the time without looking at the EKG. So structural, so when you have someone with substrate and you have wide complex tachycardia, you can have the diagnosis, you can tell it's VT. Now yes, wide complex tachycardia could be SVT that's going antidromic, the one going down the pathway and up the AV node. It could be an AV-NRT that's supposed to be narrow, but the bundles under the His bundle are sick and they give you a bundle branch block so it'll look wide. But yeah, the EKG is pretty accurate. To add one more piece to your question is location. Yes, you could use EKG morphology to kind of look for location, but studies have shown that location would be the most accurate in someone without a lot of scar. When you have a lot of scar, I just demonstrated to my fellows now. I had a VT and I was like, oh, where is this VT coming from? Oh, this is looking positive in the inferior lead, so it's heading up, down. So it should be on the top of the heart. I demonstrated that that circuit was total opposite, was coming from bottom. But there's so much scar that the exit of the VT is going up and taking the normal part of the heart activated from up, down. But the circuit is inferior. So all bets are off when you have a scar. It will just flip everything, basically. But yeah, location-wise, if you have a normal heart, the EKG will even tell you where your VT is, where you're dealing with. Yeah.
One more question, sorry. Thinking back to your slab at the beginning, which I understand is an elementary, perspective, but if you successfully ablate the reentrant, has anyone looked at like jumping over the scar then to kind of resume normal conduction?
Jumping over the scar, it's not very possible in the heart, but if you're meaning like, well, to answer the question a different way, there have been what we call painting, virus painting, jumping over the scar. So what you do is you make the scar more refractory. So I told you there are conditions you need to fill to be able to have a circuit. One, that tunnel has to be slow enough for the tissue to recover from its refractoriness. Because if it comes out of the scar and that normal tissue is refractory, it just got activated, and that impulse came out of the scar too fast, it will hit a wall. It won't go anywhere. So it has to be slow enough, just enough, for that tissue to be ready to be activated. So when it comes out, it finds a circuit that's ready to go. The other element is it has to turn around and find that tunnel again. If it turns it out too fast and that tunnel is still refractory, it again will hit a wall. It won't go anywhere. It has to have a good, big, long turn around, just enough for that tunnel to recover. And if those two conditions are filled, you have a circuit. You can go in VT. The way that jumping over, you can't really jump over there are concepts of jumping over if, let's say, the slab of muscle, we're looking at it in 2D, but it's really a 3D. So if that tunnel is epicardial, so it dives, epicardial, comes back endocardial. So yes, you have to catch it from the outside. There are also studies that showed if you transfect that tissue, the whole scar, with a virus, adenovirus, that carries a intensified potassium channel, you will make that tissue more refractory. So you change the proper electrical properties of that tissue. So, and they've used that, they're trying to use that for AFib called painting. So they go in epicardium and they paint the atrium with that transfected virus. So now when that circuit goes around the tissue and comes back, you prolong that refractory period of that tunnel so long that that circuit has to go so far and come out that it's impossible to take. So wherever it hits that tunnel, now it's refractory for a long period of time. It's going to hit a wall, it's going to collide and not go anywhere. So there are other ways to do it, radiation. So when, gamma knife for cancer, you can actually deliver a dose to the scar to kill the rest of those. You kill every tunnel in there. It's kind of the shotgun approach to this. We haven't used it yet, just because in general we have a very good VT ablation program, so we get to those, but we're ready to use it if we find someone we just can't get to the circuit and we need to use radiation for that.
Thank you.
Can you comment on hemodynamic monitoring and when you start worrying about when you've done a lot of ablations where
Yes.
how much are you creating more scar that you
Yes.
become worried about?
Yes. So my fellows asked me, can you create VT? If you can ablate so much that you give the patient another circuit. The answer is yes, you can. I've done it twice. I had to fix it, but I've done it twice. I remember them. So usually, in general, ablating, most of the circuits are in scar, so there is very minimal effect on the heart function. The way you can affect heart function without knowing it in VT ablation, if you put someone in VT for a long period of time, and then they are like blood pressure in the 90s, borderline. You think they're okay, but they're actually not. Because the heart doesn't care about blood pressure, it cares about blood flow. Most of the resuscitation trials now are focusing on that. You can have a blood pressure of 50 as long as the blood is circulating, delivering oxygen. That's what you want. This is the whole point of giving hydralazine paradoxically to someone in cardiac arrest, not epi. So when I start a VT, I start a timer because even though the blood pressure looks okay, especially when the blood pressure is borderline, because the heart is suffering during that time. And if you leave the heart for hours in VT, you can come out of that procedure with an EF half of what you went into. So because it's not perfused, your heart, basically you give the heart a massive heart attack. So you have to be careful when you induce VT, and there is a point where you say you have to stop. So whenever I induce VT, when the blood pressure is borderline, looking okay but not totally okay, I start a timer and I say, okay, no more than 15 minutes, or else you have to stop and figure out another way to do it. But in general, our ablation is in scar, and the studies have shown that the ablation itself does not affect the heart function that much. It's what you do with a hemodynamically unstable VT that can affect the heart function.
Very nice presentation, thank you. And I have a question about atrial fibrillation. When you do your PVIs and they're not successful, there are several other techniques that you can use. And what is a modern approach or current approach, and which one would you choose to proceed if you're still having atrial fibrillation?
After PVI.
After PVI.
Yes. So this is where a lot of people, so you're going to see a lot of trials in AFib ablation that came out that you got 1 or 2 trials that are positive and then 7 or 8 ones that are negative for the same approach. Because the first approach, either they pick the patients in a way to make it look positive, or I don't know why we can't replicate. So, what they did, the first wave of studies that came out, they said, okay, we're going to do PVI, but we're going to also do what we call cafe ablation. So high frequency fractionated signals that usually show you there are rotors in the heart. This went nowhere. There was one study that showed, yes, it's positive, and then like 4 or 5 other ones that said, no, it actually did not make a difference. That's because a lot of times you will see long fractionated signals. So what you're looking for, the way you define it, is aberrant, because you'll have these, if you have a normal tissue that have 2 wave fronts that are colliding in it, you will see that long cafe one. You'll ablate it, but it won't get you anywhere. They also used 2 catheters where they used one of them, like the reference would be sitting in one of them, and you can map locally your rotors. They've also done that, but it didn't go much when you did it on a randomized way. The second wave is, let's isolate the appendage of the heart. Again, 1 study that showed benefit, 5 studies that showed nothing. Let's isolate the SVC and the CS. So it was at some point kind of picking extra things to do without real evidence. The one that stuck the most is the posterior wall. So when you do the two Roukoz, the area in between the two Roukoz, you can box it. You can connect a line on top, the two Roukoz, and a line below, and you create a box. Basically, you isolate the veins and the tissue in between. Of all the studies, that's the one that showed the most promise. Still, it is not for everyone. So I've used that technique in some patients. It worked beautifully and surprisingly on some people, but some other people not so much. And there is two studies that showed that the posterior box, if you do it systematically on everyone, actually doesn't get you anywhere. So it's really who you pick. So rotors worked at some patients at a certain time of their AFib evolution. It worked, but it's a narrow window. The same for posterior box. You can do it. It adds some to PVI, but it doesn't add that much to use it systematically on everyone. As a matter of fact, it can increase the risk of the procedure if you do it systematically, because remember, the esophagus sits behind the posterior wall, so you can end up with more esophageal fistulas that are way more severe to handle. That can be deadly. You need a surgery to fix it or you die, basically. That's what it is. So that's why I haven't done posterior wall on everyone systematically.
One last question. Go ahead.
How often are you doing endocardial ablations versus epicardial, or do they sometimes go hand in hand? And can you use the same devices on the epicardial surface as the same way that you would use them in the endocardial?
Yes. So for VTs, about 10% of our VTs end up, in general, needing an epicardial access. The circuit is on the surface of the heart. We can use the same tools that we use on the endocardium. We would like them to evolve a little bit. So for example, when you use an RF catheter inside the heart, you put it on the muscle and you just deliver RF, and you're going to see that muscle scar up. You don't have any other tissue around you. When you go on the epicardium, on one side, so the catheter is sitting like this. On one side, I have the epicardium. On the other side, there's a lung. So when you deliver RF, you're ablating the lung and the myocardium. There was an idea of using a directional RF where you have like a balloon shape or a nitinol shape shield that once you deliver, you get out of the sheath, it opens up, and you can deliver RF on one side. It hasn't reached market yet. They're still doing it. I'm not sure if it has problems or not. But yeah, the tools, we use them the same. We sometimes also inject saline to separate the epicardium and pericardium. So, and you inject, like you can do half normal saline, so it's not conductive as normal saline. When you separate them now, the energy tends to go to the myocardium and not to the outside. The same with phrenic nerve. The phrenic nerve could be right there where you want to ablate. We pace for it to figure out, to make sure we're away from it. But the same, we can separate the pericardium with fluid, just to separate the phrenic nerve, so we just ablate on one side. But currently, we don't have specific tools for the epicardium. We've also talked about delivering leads epicardially. So it's been a thought of mine for a long time. Because now you have to do a mini thoracotomy or even a sternotomy in some patients to deliver an LV lead that's epicardial. If we can access the epicardium through a small puncture subxiphoid, if we get the right tools, we can deliver a lead through a sheath on the epicardium and tunnel it to the device without opening the chest or doing a thoracotomy even. So we use the same tools, but we're not happy about it.
Well, thank you very much for taking time out of your busy day and coming here and giving us a presentation and then answering dozens of questions.
Glad,
so thanks for the audience participation as well. So have a good afternoon.